Okay, so infection can cause urinary obstruction, but it usually wouldn't be painless if you've got 800, 900 mils. But it can cause that, yeah, it can do.
So if it's chronic and something's blocking it, so that BPH. Then
yeah, it could be, but that again you wouldn't expect that to cause the nerve damage. What kind of acute neurological thing would you be worried about?
Cord compression?
Yeah, it's a cord compression. So how would you manage that in that situation? Think, oh, is this cord compression or not?
Scan.
But what can you clinically do?
yeah.
Yeah, put a catheter in, it can relieve that.
You do an exam.
Neuro exam, good. So what are you looking for in a neuro exam?
Loss of sensation
Where?
on the perianal area.
Yeah, so you want to see if they have anal tone, if they've got sensation around. What else in a neuro exam would fit with the cord compression?
Paralysis?
Weakness.
Sorry? Yeah, so they could have a paralysis or a sensory level and a reflexes you want to test as well. So if someone's got a reduced urine output and then you do feel the bladder, you want to think, okay, what's the cause of it? Don't just feel the bladder and say, okay, that's fine. Actually action it and think, okay, what's causing this? Okay. So, in terms of fluid management, you have a patient who is hypovolemic. What kind of fluids do you think, and in AKI, what kind of fluids do we give usually?
Crystalloids.
Okay, so give me some examples. So normal saline, yeah.
Dextrose.
Dextrose, Hartmann's. Okay, so those are the normal ones that we can give. So what's the problem with giving lots and lots of normal saline to a patient with AKI? Sorry? So it won't cause hyperkalemia. So what it will cause is that it's got high chloride value in your normal saline, in your sodium chloride, so you can cause a hyperchloremic acidosis. So it can worsen that. It's not the potassium there is no potassium in sodium chloride, so don't worry about the potassium.
I meant hypo.
Oh, hypokalemia. In AKI, you worry about hyperkalemia,
Right.
because they become metabolically acidotic. So you wouldn't really worry about hypokalemia in renal failure, particularly, except for one or two exceptions. So the one you usually give is Hartmann's. It's advised to give balanced crystalloids because the potassium and the sodium and the chloride are more physiological. So that's what's advised by the guidelines in AKI.
Sorry, just briefly about the previous slide. So what does a painful painful reduced urine output?
So painful is good. If you've got a urinary retention and it's painful, and that's what it should be, you need to look for the cause of the urinary retention, of course. So in elderly patients, it can be constipation can cause that. It could be a UTI, it could be a number of things. But if it's painless, you just want to think alarm bells. Is this an acute neurological event, or is it something that's been chronic for a while?
Okay.
That's the only thing I was trying to highlight. So, have you heard of hydroxyethyl starches? Does anyone talk about that? So they don't use that anymore. Just in case you'd heard about starches, they used to use starch as a good plasma expander to keep the fluid in, but now there's lots of problems described about in terms of anaphylaxis and things. So the things they talk mainly about are you fluid resuscitate someone with normal saline, but in AKI think about balanced crystalloids such as Hartmann's. So we talked generally about post-renal causes, and we also talked about renal causes. So we mentioned a few. How would you categorize renal causes, intrinsic renal causes of AKI? You could do. The easiest thing to do is if you do it actually at part of the nephron itself. So if you think about the glomerulus, the tubules, and the interstitium, then you can do it like that. So there's the glomerular nephritis, so the glomerular nephritis. You have the tubular nephritis, and then you have the interstitial nephritis. So this is all inflammation at different points. Okay, so acute interstitial nephritis, acute tubular necrosis, and glomerular nephritis. Now, the thing to note about ATN, acute tubular nephritis, is that any cause of pre-renal AKI can then progress to acute tubular necrosis. And the reason why is if you are chronically hypoperfusing the kidneys, then you're not getting blood to the cells which should be there. And the tubules are the areas where there's the blood supplies the least in the kidney. So those are the bits that will become ischemic first. So you're at risk of having acute tubular necrosis. And if you have prolonged tubular necrosis, then you can have cortical damage as well. So prolonged pre-renal AKI can cause ATN. Yeah? And pre-renal is much more reversible than ATN. What are the causes of interstitial nephritis? Common causes. So you can have drugs. Drugs can cause it. So any nephrotoxins, they can cause it. So think about, actually any drugs can cause an AIN, because anything you can have an allergic reaction to, basically is very similar. You have a reaction to it, and the interstitial cells then get necrosed or become inflamed. So for a patient who's got a rise in creatinine, suddenly in the last few weeks, and they've started a new drug, you need to think, okay, is this because of the drug? So the first thing to do would be stop the drug, see what happens to the renal failure.
Would all of these not be caused eventually by pre-renal cause?
So, I mean, prolonged pre-renal won't cause a glomerulonephritis or an interstitial nephritis. Really, it won't affect the glomerular until it's chronic. So CKD will cause it. Yeah. Okay. So how do you distinguish between pre-renal and renal causes of AKI?
So what are the causes of glomerular and tubular
So
nephritis?
we're going to go into those in a
Okay,
minute.
fine.
But tubular nephritis, you think of either drugs causing it, and then there are ischemic causes as well.
Okay.
That's I meant interstitial nephritis.
Okay.
And acute ATN is can be caused by prolonged pre-renal. Any cause of prolonged pre-renal causes ATN. And there are some other causes as well. So we're talking about AKI. How do we assess a patient with we think it's pre-renal?
Fluid?
We do a fluid assessment. Yeah. So that's how we think. Okay, is this patient got pre-renal? Do they have all the signs of hypovolemia? Is that what's causing it? What about post-renal?
Bladder scan?
Yeah, so do a bladder scan, basically go for an abdominal ultrasound to look at the system, is there a blockage there? So what about renal causes?
Protein urine?
Yeah, so you want to do urine dip, right? Do urine dip, is there protein, is there blood? That will give you a very easy, quick screen to say, okay, does it look like there's a problem with that part of the kidneys? Yeah? Okay, so what do you find in a urine dip? You have protein and blood. So with protein, what are the different stages that you can get on the urine dip? Sorry?
Is that a nephritic thing?
So what do you actually physically see on the urine dip when you try to quantify the amount of protein?
Plus.
Yeah, you see pluses. So you get 1 plus 2 plus 3 plus 4 plus, yeah? So what does that roughly equate to? So what's 1 plus and what's 4 plus in terms of the amount of protein you're losing into your urine? So it's grams, exactly. So if it's 4 plus, then you're thinking it's more than 2 grams, right? If it's 1 plus, then it's less than 0.5 grams. So I have it written here. So 1 plus 2 plus 3 plus 4 plus. You don't need to know the numbers. It's just an idea to let you know that basically it's semi-quantitative, but it gives you an idea of how much protein are you actually losing. Okay? And you mentioned, is it nephrotic, is it nephritic? So nephrotic patients, what is nephrotic syndrome?
Protein losing.
Sorry?
Protein losing.
Yeah, so you're losing protein into your urine, right? And that's more than 3 grams in a day, right? So if you've got lots of pluses on your urine dip, you want to quantify it accurately to find out, is this patient nephrotic? So if you are losing a lot of protein, what then happens as a consequence of that?
Pressures change.
Exactly, so your pressures change, so your oncotic pressure goes down, so then what happens? You accumulate fluids, you become fluid overloaded. So your edematous you have got, you're losing protein, and what's the other part of nephrotic syndrome? It's a triad.
No blood. Little blood.
So compared to nephritic, then yes, it is less blood, but you can have blood in nephrotic. So these patients also have high cholesterol because of what the metabolism's different in those patients, basically. And you're overloaded, so you've got peripheral edema.
What was the first part of the trial? The protein loss?
Okay.
It's 3 grams. So they only lose 3 grams in a day, and that makes all those changes.
Why was
Minimum
the
3
cholesterol?
grams. Sorry?
Where is the cholesterol got?
So, I mean, there's not an exact answer, there's different things that people say, but if you read in certain places, they say that those patients have, because they're losing the protein, the liver then starts to change the metabolism and starts to build more lipids, just because it's out of sync. But actually, different papers say different things, there's not an exact answer to that, basically. Okay, so, now for a break. Spot diagnosis on this patient. Actually, tell me what you think about the patient. One comment from everyone. Just an observation of the patient. Any observation?
Swollen eyelids.
Swollen eyelids. Angioedema. You need to give me comments on everything. Like, what shirt is he wearing? What, how old does he look like?
How old? It looks like he's about probably
6 or 7. Good. What other observations?
Pretty high.
IgA.
Looks unwell. Good. He's got a drip. Good. Where is he?
In hospital.
He's in hospital. Good.
He doesn't look happy, does he?
Doesn't look happy. Good.
And he's lying down with a bedsheet over him.
He's got a bedsheet over him. Good.
Is it IgA nephrotic syndrome?
We'll get to that.
He's got a bandage on his left hand.
Okay, it's got bandage. Very good. Yeah. It's got
It's really strong.
Okay,
It's dark
so
outside.
he's got fluid accumulating into his preferentially into his periorbital region, and he's very young. So he may. We're talking about renal disease, so he might be nephrotic. So what's the most common cause of nephrotic syndrome in young children?
IgA.
IgA.